Ahí estamos. ¿Se escucha bien?
Perfecto.
Ahí ya.
Perfecto.
Bueno, buenas tardes a todos. Para la Sociedad Argentina de Embriología Clínica es un placer esta presentación, este webinar. Tenemos este honor de contar con el doctor Sherman Silber con nosotros. Así que les agradecemos a todos los que están aquí presentes. Nos acompaña también el doctor Fabio Sobral, que es codirector de Pregna Medicina Reproductiva y lidera lo que es el grupo de oncofertilidad en la misma institución. Así que bueno, entre los dos vamos a estar moderando este placer de webinar que nos espera. Así que el chat va a estar habilitado. Cualquier pregunta que quieran hacer la pueden ir escribiendo en el chat. Les pedimos en lo posible, si puede ser en inglés, solo para agilizar el sistema de preguntas y respuestas, que sea más rápido. Y bueno, vamos a dar comienzo. Dr. Sherman Silber, hello. In the name of all the Argentine Society of Clinical Embryologists, I want to say thank you. Thank you for being here. It's such an honor for us. It's a great opportunity to have you here, so we hope that you can feel welcome. We will enjoy it for sure. So Dr. Fabio Sobral will introduce you, and then you can start the presentation. Fabio.
Gracias, Evelyn. Bueno, agradezco la participación y la invitación de la sociedad para compartir esta sesión científica. Voy a continuar en inglés. It's a great honor for me to present such a relevant speaker as Dr. Sherman Silber. Dr. Sherman Silber is a clinician and researcher in reproductive medicine from the Infertility Center of St. Louis, Missouri, USA. He's a pioneer in ovarian and testicle transplants, being the first one to lead this area. His latest research involves also in vitro maturation, which will be part of this lecture. I want to add that Dr. Silber is a very generous person that shares his knowledge and experience worldwide. Whenever you invite him, he's always kindly helping everyone. And I had the honor to be invited at his clinic 4 years ago, and he showed me a case of ovarian desvitrification and transplantation, and they show me everything, all the tips, the techniques, the steps, whatever you need to know. All his team and himself help us a lot. So I'm very grateful and to be there and to take the advantage of learning from him. And probably everyone here will receive the same that I have received, because he's very clear in his contents in his lectures. So it's a pleasure for me, Dr. Silber, to introduce you to this meeting. Thank you very much.
Well, thank you so much, Claudio. I really, the only thing is almost as good as being in Argentina is, at least virtually speaking, to all of you in Argentina. I look forward to when I can actually come there in real life, because it's a spectacular place. I joked around before and said, first place, that's the best place to get a really good steak, but also the tango and the beauty and the wilderness. I've been to Moreno Glacier and Calafate and Bariloche and Ushuaia, and I love Argentina. But let me get on to this topic. I know you're all familiar with ovary freezing and transplantation for fertility preservation. You may not be as familiar with how easy now it is to do in vitro maturation of oocytes actually from the ovarian tissue. And that's based on our collaboration on in vitro gametogenesis with the Japanese, particularly with Katsuhiko Hayashi. So I'm going to go into that, and I'm not going to get through everything. So I'm asking to be invited back again, and I'm going to try to do my 40 minutes and then do questions and answers, and then we can continue at a later date. So, it's not, let me see. For some reason, my slide isn't moving. wait a second, I apologize, but something isn't, the computer.
No, it's okay. If you want to close the window and then
Open again.
open again.
That's what I think I'll have to do that. Stop share.
Doctor, yes.
And, yes, go ahead, and then share again. Maybe that's what I have to do. Yeah, it's going to start. It's going to work now. I apologize. So there's, can you hear me well?
Perfect.
Okay, so this is a list of things I want to talk about. We won't get to all of it. IVM and in vitro gametogenesis, oogenesis is probably the most important. Ovarian longevity, frozen ovary transplant results. Even we're doing ovary allotransplantation now for Turner syndrome. And even we're using skin biopsy in the human to make eggs. And we're about halfway there in terms of making PGCs. So we can't discuss it all in one talk, but they do all sort of work together. So let me just go a little bit historically. What started it originally was an unusual series of identical twins discordant for ovarian failure. I think it's interesting just to go into the history. Now, Crystal's eggs were quite fertile, and we can tell you that until she was 46 years old, and I can explain that. But Bonnie was born with no eggs. So Crystal already had 2 children, and Bonnie had ovarian failure when she was 16 years old. So this transplant that we did from Crystal to Bonnie, they were identical twins, was still working 8 years later. And she actually got pregnant spontaneously and had her 3rd baby at 46 years of age. But what's maybe more fantastic now is that Bonnie and Crystal are now 55 years old, and we're making young germ cells from them. So we'll go into that in a bit later, but when we do in vitro oogenesis, we're just recreating embryology. And so therefore, when we get the PGCs, they're primordial germ cells, they're extremely young. I mean, they're fetal germ cells. So this is going to really make a historic difference in what we're doing in about 10 years from now. But the original question we asked was a very innocent one. These were interesting cases that came to us, identical twins discordant for ovarian failure. Now, our question was, if the reason for discordancy for ovarian failure in identical twins is misallocation at the time of splitting, we could determine in the human embryo when germ cell specification occurs by the obstetric history. Because the question was there a genetic reason or an epigenetic reason that one identical twin had no eggs and the other one had a normal ovarian reserve? And we postulated maybe it's not genetic, but just misallocation in the early embryo at the time of germ cell specification. So it all starts in the early epiblast. There are cells which are destined to remain eternal, and they're separated from the rest of the developing embryo. So the rest of the developing embryo is going through somatic development, but these cells that are specified to be germ cells have to be separated off, and they actually are outside of the fetal body, as we know, at least in the human, until approximately 3 weeks of fetal life, when they begin to migrate towards the dorsal ridge. So in vitro gametogenesis just copies this in vivo process. But if we could generate germ cells from iPS cells of identical twin with ovarian failure, that would rule out an epigenetic or genetic error, and leaving the only possible explanation to be germ cell misallocation at the time of splitting. So when does that specification occur? That's what we were interested in doing. And we started a project that's actually funded privately, but we have no intention to use this for money making. It's all within a university program at our center, UCLA, and University of Pittsburgh. And that's our team. And this is Katsuhiko Hayashi that I think made all this possible by being the first person in mice to convert skin cells to stem cells, and those iPS stem cells convert to functional eggs, which would then be fertilized by mouse sperm and resulting in a baby mice coming from the skin cells of the mother and not from the ovary. And this is Katsuhiko and his assistant Ori, who did most of that early work. And this is Amanda Clark, who is helping us to apply this directly to the human, which we're doing with the UCLA Stem Cell Center. So what is this project all about? Well, in the mouse, we can make iPS cells from skin cells from the mouse's tail. These iPS cells are then transformed to PGCs. We incubate these PGCs with fetal granulosa cells, and we're just recreating what happens normally in the fetus. So you get fully competent oocytes in normal baby mice. Now, applying this to the human, we now have many beautiful PGCs derived from a simple skin biopsy of menopausal women. And they're young PGCs, obviously. So we need to make human fetal granulosa cells in order to finish the job of transforming from PGC to functional oocytes. If in vitro we were to use adult granulosa cells, nothing would happen. We need fetal granulosa cells to convert PGCs into oocytes. This is all recreating the fetal process. So we're just doing simple punch biopsies on all our menopausal women or women with premature ovarian failure. And we're doing this, by the way, on men with azoospermia as well. We put it in a little tube and send it to UCLA. And from UCLA, we generate from skin cells, we generate iPS cells or stem cells pretty easily. And then we've succeeded in converting those stem cells into PGCs. So that's pretty amazing. So we have young PGCs from 55-year-old skin cells. Think about this. In the future, a 38-year-old woman might be better off having a skin biopsy than an oocyte retrieval for IVF, because the eggs we're going to generate from a skin biopsy are going to be younger, more fertile eggs than what we'll get from her ovary. But our original question, it was really maybe a minor question really that led to this absolutely incredible development. We're dating monozygotic twin splitting. Answering our question, when does germ cell specification occur in the early embryo? Now, the obstetric history of these women who were discordant for ovarian failure virtually always showed they were monoamniotic, monochorionic. And mono condition only occurs in about 2% of homozygotic twins. So it's pretty rare. And in fact, we don't like to see it. It's not exactly a safe pregnancy. But if more than 12 days, you'd actually have Siamese twins. And it's between 9 and 12 days that you have monochorionic, monoamniotic twinning. And that means that germ cell specification in the human has to occur in the epiblast sometime between 9 and 12 days of embryonic life after fertilization. So I thought that was an interesting question, and this is the only way to answer it in the human. But what this led to is a whole technology of in vitro maturation at the time of ovarian tissue cryopreservation based on in vitro oogenesis. And, you know, I'm going to stop early enough because I'm looking at my watch so that you can ask questions about this, because since it's not exactly interactive yet, I don't know, you know, to what extent you're following all this. So our research goals originally were to report the pregnancy results for cryopreserved ovary tissue transplantation from one US center, and we'll report that to you. But we're also now doing in vitro maturation of oocytes dissected from the ovarian tissue at the time we do the ovary freeze. And we're able to do this. It's amazingly easy. You can start doing it tomorrow using knowledge gained from in vitro gametogenesis. So in vitro gametogenesis is tricky, but to apply it to doing IVM is remarkably simple and shocking. So we have 17 cases that came back up to 22 years later to have their ovary tissue thawed and transplanted back. And this is how we would prepare the ovary tissue. Now, for a while, I was using a slicer to get thin cortex. But since now what we want to do is also have M2 oocytes, we go back to our old Gosden technique for dissection. And if we get the cortex thin enough, it works just fine for vitrification. So this is how we do the ovary dissection. Now, if you do it on ice, you'll really be making the cortex much healthier by saving it from warm ischemia time. But on the other hand, that reduces your transformation of GVs to M2 somewhat. So we no longer dissect under ice. But nonetheless, this is the first such case, and we got plenty of M2s from this. So you can do it on ice if you're more concerned about saving the cortex. So we dissect away the medulla, and we make it very, very thin. You can see those little craters where they were developing GVs that then actually just were left behind in the spent media. And we, as you probably know this, we cut the thinned out cortex into small enough pieces, 1 centimeter by 1 centimeter by 1 millimeter, and we vitrify it. And our vitrification is fairly simple. The media is 7.5% DMSO and 7.5% ethylene glycol with the usual 20% protein in heaps. But then after it's been in this solution, we then go to the vitrification solution, which is 40% cryoprotectant. And it's 20% ethylene glycol and 20% DMSO, and it is very, very dense. We leave the tissue slices in the equilibrium solution for 25 minutes, and then place it in the vitrification solution until these thin tissue slices fall to the bottom of the centrifuge tube. It is so simple. In other words, you want to make sure that all the cryoprotectant has been absorbed. And since this cryoprotectant is so dense and viscous, the tissue floats at first, and when it's finally fully absorbed, it then sinks to the bottom, and that's when you know you're ready to vitrify. So we'll just show you some illustrations of this. When you first put the slices in the equilibrium solution, they just float to the top. And in fact, you have to turn the test tubes upside down and in order to get them to float to the top again and fully absorb. And so that's the way it normally looks. But then after you put them in the vitrification solution for a while and it's been there long enough, then they eventually begin to descend to the bottom, and that's when you know you're ready for vitrification. This is and we use a different platform than we used to use for holding the, because we can't get anything from Tejido anymore, but we have these really lovely platforms, very, very simple, in which we put the thin slices of tissue. You can see it's very easy to just take them and put them on there. We want all the fluid to come off, because you don't want any fluid on the surface of the ovarian slice. You only want it into the ovarian tissue, because if it's on the surface, it'll slow the rate of freeze. And of course, the whole secret of vitrification is rapid freeze. So there you can see we get the platform loaded and we just throw it in liquid nitrogen. It's very, very simple. And then for the thaw, we just immerse this metal strip directly into a large volume of 1.0 molar sucrose at 37 degrees for at least a minute, and then transfer it into 0.5 molar sucrose for 5 minutes, and then we wash it twice. So it's very, very, very simple, and no ice crystal formation occurs. And the reason you have to put it in such a large volume is because you don't want this cold tissue to warm up the media you're putting it in. And, you know, the histology shows you can't tell the difference in the ovarian tissue before the freeze or after the freeze. Now, then when we do the ovary transplant, we suture with 9-0 nylon under the microscope. We suture these pieces of tissue together because it's much easier to do the transplant if it's one united piece than just a group of pieces. And you can see we've finished transferring. We've actually put 6 pieces of ovarian tissue together, and then we transplant it onto the dead ovary or to the ovarian ligament. And it's very important to put it in a position where the fallopian tube can reach around and grab the egg when it's ever ovulated, because doing IVF with these cases of ovary transplant is very difficult. It can be done. You don't get many eggs and it's difficult. It's much better and easier just to let the patient get pregnant naturally with orthotopic transplantation. So all of our pregnancies really we allow them to just get pregnant on their own spontaneously. So every patient had return of ovarian function 5 months after transplant, similar to previous observations, and AMH rose as the FSH went down 4 months later. So, and the graphs all continue to work for up to 8 years. It's very important to understand that as the FSH comes down 4 months later, the AMH goes up. And that's really important in terms of understanding ovary function. I'll get to that in a little bit. So 76% became pregnant just with intercourse, at least once, resulting in 19 healthy babies, and including 6 live births from 3 leukemia cases. But 35% of harvested GV oocytes developed with simple culture media into mature M2 oocytes. Now, this is the relationship of FSH to AMH. And you can see by about 4 months, the FSH comes down to near normal. It can't be normal levels because we're not really transplanting an entire ovary. We're just transplanting 8 pieces out of 20. But the FSH comes down after about 4.5 months, indicating that after recruitment of primordial follicles, it takes 4.5 months for the primordial follicle to become a GV that is sensitive to gonadotropin. At the same time the FSH comes down, the AMH, the blue line, goes up to very high levels for a period of up to 8 months. And then it comes down again to very low levels, but continues to function for about 8 years. So what's happening is that there was a massive over-recruitment of primordial germ cells at the time of the transplant. And you only see that in terms of an AMH elevation once the primordial germ cells have reached the gonadotropin sensitive phase 4.5 months later. But then as the ovarian reserve goes down, so we lose a lot of eggs just from massive over-recruitment of primordial germ cells. But as the ovarian reserve goes down, the rate of follicle recruitment goes down. I'll explain the basic science of that in a little bit. But so these pieces of tissue can last for a long time, for 4 to 8 years, despite very low AMH levels. And you can see what we consider to be a normal AMH level post-transplant is actually very, very low. I mean, you can see it's about 0.2, and they get pregnant. We have one lady that had 5 babies with an AMH of 0.2. Oops, it's not, I'm locked again. I don't know why it locked up on me again. Well, maybe I need to.
We can do the same.
Do the same thing, yeah.
Yes.
I'll stop share and then go back again.
The,
Okay, and then I'll start sharing. Guess I don't know why that happens. And now it's moving again. I would like you to look at this video. This is really heartwarming. Listen to
There's
this.
never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital, and we're about to do the first case in the St. Louis area of ovarian tissue freezing.
Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that age, came down with a terrible case of leukemia. We thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did, and we're the only ones right now really actively with a program in the whole United States. And it's been a long time, and we didn't know that we'd be able to transplant the tissue back, and we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago. She was happily pregnant, and now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary, and beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace.
So I have many other cases to show you of this. I'll show you one more here.
Dr. Sherman Silber, Infertility Center of St. Louis, and I'm here with the most amazing fertility story ever. This is Amy Tucker. I've known her since she was a little 19-year-old girl who was facing death with Hodgkin's disease, a terribly difficult case. And she's got 2 children from her frozen ovary that we froze before she underwent her chemo and bone marrow transplant that sterilized her. And she's now pregnant with twins. She's going to wind up having 4 children from this ovary we froze before she had this life-threatening.
And then one more I'll show you, because I just think these are touching.
The fact that I couldn't have children really scared and frightened me.
2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get, and I came across fertility, and I burst into tears. I don't have a biological clock anymore. He took it away from me. So when I'm ready to have kids, it's not going to be a problem.
Well, Melissa, this is a fantastic moment for all of us. I mean, when are you going to have the baby?
We are scheduled for a week from yesterday, so 6 more days.
6 more days, and you look really ripe.
I am very ripe, yes.
Okay, the reason I showed those is because when you usually don't tape an interview ahead of time with the patient, and we didn't know how good the results would be, but it's just so dramatic and heartwarming to see that with the exception of Melissa, most of these women really were, they had no confidence they would ever have children. They felt they would survive their cancer despite how severe it was. But we were all surprised because we started doing ovary freezing, not having any idea if this would really work, even though we knew from Gosden's brilliant work that it did work in sheep. But we didn't know if we'd ever even apply this in humans. We just froze it because there was nothing else we could do. We couldn't freeze eggs at that time. At any rate, this is just a summary of these results. And you can see whether we use vitrification or slow freeze, the results are just as good. And but we all use vitrification because we find it so much easier and simpler and cheaper than slow freeze. And you do preserve more oocytes. So slow freeze will destroy half the oocytes, but if you're dealing with 400,000 oocytes in ovarian tissue, then destroying half of them doesn't really matter that much. But vitrification is better from the point of view of saving oocytes, but our results seem to be the same no matter what the method of freezing. But what about leukemia? Everybody's afraid to do leukemia, but Klaus Anderson was able to show that if you remove the leukemic patient's ovary after they're in remission, but before they have another recurrence and undergo bone marrow transplant, there will not be viable cancer cells in the tissue. And that's verified by all kinds of staining by the oncologists and the pathologists. So leukemia doesn't mean you can't transplant the ovary tissue back. In fact, that one of the patients with 5 children had acute myeloid leukemia, and she has 5 children from the transplant, and the ovary is actually still functioning in all these leukemic patients. But what about another approach, in vitro maturation at the time of the ovary freeze? This is spectacular because you eliminate any fear of transmission of cancer, and it just gives another option for the woman to get pregnant. She doesn't have to undergo ovary stimulation to get eggs. She doesn't, and if the freezing runs out of eggs, she's got good M2 oocytes for IVF. So again, the whole secret is do not discard the media. That's where the GVs are. And we take the spent media and we look through the large Petri dish, and we can usually find anywhere from 10 to 60 GV oocytes. And what do we do then? Well, this is shockingly simple. And I'll explain to you why when I go through in vitro oogenesis. I'll make sure to get to that before we're done today. Any IVF culture medium, we tried everything. IVM media is no better than non-IVM media, any media. The usual human serum albumin, no big deal. And then you can use 150 milli-IUs of HCG, or frankly, any other concentration. It really doesn't matter what the concentration is. You can use 150 milli-IUs of FSH or any other concentration. Now, many people just use Menopur. We've tried Menopur, and that's just got 10 milli-IUs of HCG and 75 milli-IUs of FSH, and that works. So a very low concentration of HCG, and I actually uses 1,000 milli-IU of HCG per milli-IU. So it really doesn't matter what the concentration is. And so now when you're dissecting the tissue, these are a series of histologies to show you that up above in the outer part of the cortex are all the primordial follicles. But as you dissect the cortex so you can do the freezing, these GVs down here are going to just, you won't see them when you're doing the dissection, but you'll find them in the spent media. There are different phases of maturation. You can see that histologically. But they're all GVs. They're not mature, but this one is about to become mature. And this is what it looks like when you, in the IVF lab, when you pick up those GVs, what you're really seeing is a oocyte with a very compact cumulus, an immature oocyte. And you culture it then in any concentration of HCG in any media you want to use, and you wind up with 35% developing normal M2 oocytes. And this is sort of a summary of the first 13 that we did. And you can see there's a wide variation. But look at the second case. There were 11 cumulus complexes, and we really shouldn't call them GVs because you don't know until you dissect off the cumulus. But the cumulus was stripped immediately, and we only got 9% IVM from that one. So you must leave the cumulus on. But the variation otherwise can be anywhere from 20% to 56%, and an average of 35% of these cumulus complexes that you get will develop into good metaphase 2 oocytes that can be used for IVF. Now, it's this widely variable media can still results in similar results, no matter what you use. So when we use anywhere from 10 milli-IU of HCG to 1,000 milli-IU of HCG, we got 32% maturation to M2, even with just using cleavage media. Klaus Anderson, who I consider to be the really world's expert in this, would use 75 milli-IUs of recombinant FSH and 100 milli-IUs of LH, and he got 31% maturation rate. Seegers, who's one of the greats in this field and has had live babies from these oocytes, uses 75 of Menopur and 100 of milli-IU of HCG. Hayashi, who did the in vitro gametogenesis, used actually 1,200 milli-IU per ml of HCG. and it didn't make any difference. It was still 30% maturation. Now, Anderson actually studied the ploidy of these oocytes, and the first 53 M2 oocytes he looked at, studying their first polar bodies, indicated that 64% were euploid. And that's really normal. That's normal for any of these young women. The metaphase 2 rate was 1 in 3, resulting in a total number of M2 oocytes that was similar to the number they would obtain from ovarian stimulation. Now, you wonder about live births. There are live births reported with it. Sometimes it takes a while before these patients come back to do IVF, but there's every reason to think that these metaphase 2 oocytes are normal, viable oocytes. Why does it not require special IVM media, and why does it work so easily? To understand why IVM works, you must understand in vitro gametogenesis. Now, this is just the outline in the mouse of making eggs that really works from skin cells. First place, understand primordial follicles are no good. You cannot really mature primordial follicles into a metaphase 2 oocytes. They're locked by two things. FOX3 is intranuclear and tissue pressure. And remember, I showed you that when the FSH comes down, the AMH goes way up because of massive over-recruitment at the time of the transplant. That's because of a reduction in tissue pressure. For those first 4.5 months of development of an oocyte after recruitment from primordial follicle to gonadotropin sensitive oocyte, the only thing governing that is tissue pressure. Gradation in tissue pressure is what governs that inexorable recruitment of 30 follicles every day from the primordial pool, 1,000 a month, until you finally run out of eggs. It's not magic, it's simply tissue pressure. Plus, there are 8 core genes you need for this to be accomplished, but the 8 core genes still can't do it if there is tissue pressure. Now, at any rate, you can develop skin cells to iPS cells in 3 to 4 weeks. And that's we know how that works with 4 genes. iPS cells to epiblast cells in 2 days, and epiblast cells to PGCs in 6 days. And you just have to use the right genes that you can purchase easily commercially. And Hayashi determined what genes to use just by looking at the transcripts from embryos at different stages of development. So then what happens to the PGCs is a process called IVD in fetal granulosa cells for 3 weeks, in vitro differentiation, in vitro development. FSH culture then is IVG, that's gonadotropin related development, and it's remarkable that it's 11 days. Exactly what we find in the humans when we stimulate them for IVF is 9 to 11 days of stimulation. And if you put them in FSH culture longer than that, you'll get post-mature oocytes. And if you have it not long enough, you'll get GVs that don't develop. And then HCG culture with FSH for just 1 day, and that's the IVM, and you get metaphase 2 oocytes. This is sort of a diagrammatic picture of that to just show you and understand the difference between these 3 phases of development that occur naturally in the ovary, but also can be recreated using stem cells. So the only difference is that naturally in the ovary, there's a phase of oocyte arrest caused by pressure of the cortex, but that doesn't really happen with in vitro gametogenesis. We don't have that pressure buildup. And so the PGCs go directly to secondary follicles in the presence of granulosa cells, fetal granulosa cells, and then they're sensitive to gonadotropin.
Otro color que hay es azul, azul.
What? Let me just go one more step. This is just another picture of IVD, IVG, and IVM. And why do we need ovarian stimulation or even the normal ovulatory cycle? We now know we do not need ovarian stimulation for oocyte maturity. FSH has already created GVs with meiotic competence. We do not even need the normal ovulatory cycle for meiotic competence of GVs. We only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and normal monoovulation for oocyte retrieval. The only reason we need follicles is to get the oocyte out of the ovary. Why does IVM work? There are many GVs inside the medulla that have had adequate time of exposure in vivo to FSH. That is because there are so many of them. 30 per day were recruited from primordial follicles 4 months earlier. It is much easier to collect many GVs from these tiny follicles with the ovary in hand instead of using a needle, because you don't even see them. 35% of these GVs have already been made meiotically competent from in vivo exposure to FSH for 10 to 14 days. Now I'll end with this simple diagram, and I have many more slides to talk about, but I wanted to make sure we got to IVM, and you'll understand why it's so easy to do if you just look at this simple graph. Now, IVD is going to be a 4-month process where the primordial follicles based on pressure gradient are recruited 30 a day or 1,000 a month to develop over a 4-month period to finally become GVs that are sensitive to gonadotropin. That gonadotropin sensitive phase then can go on forever because the FSH is there all the time, with a little bit of LH, of course. But we know from in vitro work that 11 days is about what you require to have an adequate exposure to FSH to allow HCG to mature the GV into an M2 oocyte. Now, if you look at that, there is a sweet spot, I call it. If you look at the pink area, if the oocyte has not been exposed to FSH for long enough, it'll remain a GV that is insensitive to HCG and will not become a metaphase 2 oocyte. But if it's exposed to FSH for too long, which is like more than 4 days, then it will just degenerate because it's post-mature. So think of it, 4 out of 11 or 12 days correlates with a 35% maturation date. So therefore, at any time that you retrieve these GVs from ovarian dissection of the cortex, 35% of them have had enough, the right amount of exposure to FSH to be in the sweet spot where they will naturally mature with exposure to HCG. So that is why we know from in vitro gametogenesis and from really understanding much better how the ovary functions, that's why IVM is so easy. We're not using primordial follicles. We just collect the GVs, and it doesn't matter what media you use, and it doesn't really matter what concentration of HCG you use or LH, you will get maturation. Actually, let me just show you what that looks. Well, this is the team that I work with in Japan to work all this out. And I can go into much greater explanation of it or answer questions if we have another session. But just to let you know that the end result is of this complex study of ovarian physiology is that IVM is very, very easy and doesn't require any special media. So maybe I'll stop there so we can have time for questions.
Thank you, Dr. Silber. I think that this in vitro vibration media thing is shocking, because in Argentina we thought that it was a limitation for us. We don't imagine that we can in vitro modulate the GVs because the media is difficult to get or it's expensive, etc. So this is very important for us. All the in vitro modulation thing that it works with even a simple culture media.
Well, it is shocking. It was shocking to us too, but it makes perfect sense when you finally understand how the ovary works. I mean, a lot of people are in the dark about how the early oocyte in the fetus begins to undergo meiosis, but from exposure to retinoic acid and upregulation of STRA8, but then it immediately gets arrested. And if it wasn't arrested, then meiosis would continue and all the oocytes would be gone when the girl is born. Before she's born, all the oocytes will be gone. So it has to get arrested, and it's arrested in the oocytes in the fetus that migrate into the developing cortex of the ovary, because the tissue pressure in the cortex halts that development. And I have slides to show you later that's interesting. When we are making artificial oocytes from stem cells, if we culture them in an incubator that has high atmospheric pressure, they don't develop. And when we take them out of that incubator and put them into an incubator with normal pressure, then they develop into oocytes.
Very good. Dr. Silber, wonderful what you explained to us. I'm a clinician, so I want to make a little remark just to be clear that it's important to know that with a needle, it's very difficult to get those GVs, but with the tissue, you have this wonderful experience, no? So it is possible to think in the future that making, not for these oncologic patients, but for clinical patients, to remove via laparoscopy some patch of tissue to take that compression of the ovary and can get GVs from that, and afterwards do also an stimulation, could share both techniques to improve results. It makes sense?
Well, absolutely. Now, one of the two reasons why IVM has been so impossible to do in the past is that it's very, very hard to needle these little tiny follicles, and you're really not going to get many of them. There are so many, but if you have the ovary in your hand and you're just dissecting it, you don't even see these follicles. And it's not until you look into the spent media that you see all those cumulus complexes. And so we have an advantage if we've taken out the whole ovary.
Sure.
And the second reason is to get IVM, people would give the patient doses of HCG ahead of time, or high doses of FSH or stimulate. And that really disturbs the natural process, because 35% of those oocytes are going to be ready for HCG at any time ever in their cycle. It has nothing to do with where they are in their cycle. So those are the two problems. But I anticipate in the future, if we can get good enough visualization of these tiny follicles, then we could needle them more effectively. Right now, I don't think ultrasound visualization is quite good enough to, it's very hard to needle these.
Sure.
Sure.
Thank you.
I have a question here. How do you prevent the ischemic reperfusion injury?
That's very interesting, the ischemia. Well, okay, I'm going to talk about this in another session if I'm invited, but we've done ovary allotransplantation. And in other words, where it's one sister to another, they're not identical twins, they're undergoing immunosuppression, and we also check for ABO compatibility. Now, when you're doing a solid organ transplant, you have to have ABO compatibility. If it's ABO incompatible, it doesn't matter how good the HLA match, there will be thrombosis and no vascularization of the transplanted organ. And so and it happens very quickly. So that became a tool for us, because when we did an allotransplant with absolute ABO incompatibility, it worked. And I mean, with their immunosuppression, they're HLA identical, but they're ABO incompatible, and it worked. So what that proves to us, at least in that case, is that the ovary, like a skin graft, the ovary graft, like a skin graft, functions on diffusion rather than vascularization. Now, vascularization is nice, but diffusion is critically what allows it to survive the same way a skin graft survives. And so I don't think that we're losing oocytes from ischemic damage. I'm sure we're not. We're only losing oocytes from the drop in tissue pressure that allows all these primordial follicles to suddenly get massively recruited.
Ok.
Good.
¿Leo otra, Fabio? ¿Querés que lea otra acá?
Sí, sí, sí.
Sí. We have another one. What is your opinion about the commercially called augment and the platelet-rich plasma therapies for ovarian?
Oh, wait, say that a little slower because my hearing isn't so good.
Okay. What is your opinion about the commercially called augment and the platelet-rich plasma therapies for ovarian?
Well,
Rejuvenation.
yeah, I think ovarian rejuvenation is not valid. I think it's just a moneymaker, but you can't really we've really studied this well, and I know there's an argument that you have ovarian stem cells that just have to be activated, and that was based on Kawamura's. Kawamura, interestingly, removed ovarian cortex from young women with premature ovarian failure, and he was able to get some eggs that way. But you can see, of course, that would happen because you're releasing the eggs from the tissue pressure of the cortex. And since, as I said, the rate of primordial follicle recruitment goes down as the ovarian reserve goes down, when a woman finally stops menstruating and is menopausal, there are likely to be a few oocytes still trapped in that cortex. And so just the dissection can free them up. The culturing with P10 and all that doesn't do anything. It's just a matter of releasing the pressure. The real control of development of those oocytes from primordial follicle to oocyte is 8 core genes, which I'll talk about next time. That's what these core genes are necessary, but they are controlled by tissue pressure. So I think ovarian rejuvenation with some products is a lost cause. But we can do a skin biopsy and convert those skin cells into stem cells. And those stem cells right now we convert into PGCs. And I don't think it'll be very, so what we need to do to convert those PGCs into functional oocytes in the human is we need fetal human granulosa cells. Well, now we have a system for culturing the stem cells, the iPS cells. We can culture them in a different set of transcripts and come up with fetal granulosa cells. Then we take those two different cultures, the PGCs and the fetal granulosa cells, all developed from skin, and we put them together.
We'll put together.
And that's why we expect in about 5 years we will have human oocytes from skin cells.
Nice. You have another question here from Natalie Beth Barrera. Did you find the same competence in oocyte maturated by 24 or 48 hours?
Boy, that's a great question. How long? Usually, as you might expect from all of our IVF work, it's somewhere between 24 and 48 hours is where you get most of the M2s. So that poses a problem because, you know, we normally at 24 hours, you can safely remove the cumulus. And you'll have some metaphase 2 oocytes, but you're really not going to get the maximum number until you're at about 36 hours. Now you can cheat and just look at it at 48 hours and you'll still get some pretty good M2 oocytes, but the sweet spot is going to be at 36 hours.
Thank you. I make you a question, Dr. Silber. Do you think that your high success rate in pregnancies is related to the technique, the microsurgical technique you follow since you began with this, compared to the laparoscopic techniques of strips or tunnelization, that as you use more amount of tissue and you stitch it to the ovary, could make better results?
Well, I do think so. And the reason for that is that we don't have microhematoma underneath the graft or in between graft pieces or slices that will interfere with diffusion and eventual revascularization. So I think that it's really important to get the tissue properly flat on its bed with enough pressure that you don't have microhematoma forming. And furthermore, you really want them to be able to get pregnant spontaneously. If you have to resort to IVF, you're going to have a very hard time. You might get 1 or 2 eggs at most, but it's very difficult IVF. And then when you put the needle in to try to aspirate the follicle, you can push the graft off from the bed as well, and you can damage it. And IVF is a different, and that's why people are, I believe, are getting low success rates, 20%, 30%, because they're not relying on spontaneous pregnancy. It's important to, with microsurgery also, we're constantly irrigating with heparinized saline, which is the best way to avoid adhesions. And we make sure that the graft is in a place where the fallopian tube can pick it up. Now, if a woman has had her fallopian tubes removed, then you're stuck. You just have to suture it to the peritoneum, and all you have left is IVF. But hopefully those women will have many more metaphase 2 oocytes already obtained from in vitro IVM at the time of the oocyte freezing.
Good, thank you.
I have a question here from Sergio Romero. A comment on premaduration and IVM for PCO patients, work done in Belgium and Vietnam.
The problem with PCO, I mean, it works, but it's a low success rate, but it works. It's okay to do that. The problem with PCOS is that these women have huge numbers of eggs, and the vast majority of those eggs or GVs have been there for a long time, and they've been exposed to FSH for too long. And so they will be out of the sweet spot. So often you try to stimulate them a little bit and then retrieve the eggs, but that doesn't solve the problem, because the problem is with PCOS is that a large number of those eggs that you can easily needle are going to be, if had too long an exposure to FSH. So it's different when we have the ovary in hand, because we can get these really tiny follicles that have only had exposure to FSH for the sweet spot period of time. So PCOS is very difficult. Is if you can actually needle those follicles, they're probably going to be pretty old eggs. But you can have success. It's not going to be as high as you'd hoped it would be.
Okay, thank you. I think that we are done with the questions. I don't know, Fabio, if you have another one.
Well, I can
a lot of, but
the whole night with Dr. Silber, because it's incredible to hear him. Such a pioneer in each field of the reproductive medicine. It's wonderful to hear you. So I will stop here because you won't get to your bed.
An hour is about all people can take, but let me go to escape for a second if it'll work. And I want to show you where we're going to where we'll start. And I'm going to stop share and then share again. I never knew you could do this. And oh, wait, I didn't, that doesn't, I want to show you where we're going to start again, but I didn't do that one right either. Okay, so remember this graph. Okay. Okay, I'm going to start, next time you invite me, we'll start with this graph.
Okay.
And that will be an easy way to remember the dynamics of how the ovary really works in IVM. And I'll go from here further, because I've made a few statements and answers to questions that I need to back up, and that's what I have other slides on. So I think we'll start here next time, if you're kind enough to invite me.
Yes, please. We take your word.
Okay, fantastic. And you can be, you're invited to come to St. Louis, by the way, if you like. Whenever you can travel, that would be great. So thank you very much.
Thank you. Thank you, Dr. Silber. It was a pleasure. And so you're invited to come to Argentina whenever you want, virtually or in person.
Okay, fantastic.
We hope that in person.
Well, we hope so. Maybe it might be in 6 months that we won't be worried about COVID anymore. We can travel more easily, you know. I really think Argentina is such a beautiful, amazing country. You're very lucky to be living there.
Sorry, can I question?
There's one more question.
Yes, I am wondering what is your opinion about, you know, premature in vitro maduration step that some people use nuclear inhibitors in the media before starting the in vitro maduration.
You know, I'm not quite sure I understood the question. All right. You know, my hearing isn't good.
What is your opinion about a premature step in vitro maduration using inhibitors for nuclear maduration?
Oh, wait, let me see if I understand. You're talking about the theory that you have to prevent premature development of the oocyte.
Like some people use like inhibitors in the media before starting the step of IBM, like many are animals and some in humans, and they say that they get better rates.
Yeah, I remember that came out of Australia and China, and there's a lot of theories about that, but I don't think so. I think you don't want to interfere with what is naturally there for you. You can see that our rate of IVM goes from like 20% to 56%. And so in some patients, you're just going to get more than in others, and it's a variable. But we can have huge percentages of in vitro maturation in 1 or 2 cases. So I don't think there's any evidence that adding that, theoretically, it doesn't make sense. If you look at the theoretical model for egg development based on in vitro oogenesis, it doesn't make any sense to stop the process. Just continue the process and know that there will be, on any given day, any time at all in the cycle, there are likely to be 35% of those cumulus complexes that are in the sweet spot of 4 days with enough exposure, maybe more than 7 or 8 days of exposure to gonadotropin, and they haven't gone too far into the post-mature stage. So I think we'll start it. You'll get it better. You'll understand this all better if next time, and I can do this next week or next month, whatever. If we start with this slide and then we go into the details of in vitro gametogenesis, I think you'll understand it better.
Wonderful.
Perfect. Thank you very much.
Okay, thank you so much.
Thank you, Dr. Silber.
Okay, appreciate it.
Have a good time. Bye-bye.
Wow, there's